So what we want to do actually is to give you an overview, and a lot of this stuff is going to be actually repetitive for you, but is the role of promotores and community health workers and how basically they help in the process of patient navigation through the healthcare continuum. Obviously, one of the things that there has been a misperception with, I would say, social workers around the country is that social workers don't want to work with community health workers or promotoras because they see, well, they're kind of duplicating our work, which is not the case. We all know that social workers are trained holistically, so we are trained to navigate people through social services because that's one of the trainings. A lot of the caseworkers in institutions are social workers. So they think that the promotoras or community health workers are going to be duplicating the same work that we do, which is not the case. So basically, what happens is, when what I want to demonstrate to you, and because I'm bringing in the model that we utilize at the Ralph Lauren Center for Cancer Care and Prevention, Dr. Harold P. Freeman, who is the founder of the patient navigation world. Let's put it that way, because he started the program, he got the legislation passed, and then he created the Ralph Lauren Center under the patient navigation model. So what we actually did at the Ralph Lauren Center is implement a patient navigation model, which included actually the part of the community as well as the navigation through the healthcare facility. So what do promotoras and community health workers actually do? You motivate folks to get into screening, right? To change behaviors and come into a healthcare setting to get screened. Obviously, we inform people that, especially those of us that have worked in immigrant populations, a lot of the barriers that prevent people from seeking health care, especially if they're undocumented, right, is the fear that personal information is going to be shared. So part of your work will be to say, okay, we're going to get you into screening. You have probably no insurance. Your information is not going to be shared. Your rights as a patient is completely confidential. We just want you to come in and get screened. We want you to be part of the healthcare system because if you have any sort of health problems, we want you to get early treatment with the hope that we get a cure in the case of cancer. Now, obviously, part of the work of a community health worker is not only bringing in the person into screening, but also identifying barriers that keep people from going into screening, right? Seeing what resources are available, because if a person says, well, I cannot go and get screened because I have no insurance, then you have to find a way, okay, don't worry about it. We'll take care of it. We have a program that will cover the cost of your screening. If you get a diagnosis, we'll get you the resources so that you can get your treatment. Or if you have issues with transportation, we'll get you the transportation that you need. And obviously, a lot of the issues that prevent people from going into screening, because they really do not understand what health problems they can be exposed to, whether it's obesity, whether it's arthritis, whether it is cancer in the case when we were dealing with Ralph Lauren. Now, as you can see, there are different roles that in a health setting, and how a social worker has a role to play, the community health worker has a role to play, a navigator has a role to play. So basically, all of us are in the process with the doctor, with the nurses, whoever is involved in the care of that particular person. Okay? So one of the things that we do as community health workers, promotoras, is we learn. We understand what we need to transmit to our people, the people that we're trying to get at. Most of us actually will be working in the communities that we represent. because we understand what our needs are. And I'm not going to go into the whole thing because it's very lengthy, because we want to go into a discussion, but we understand, obviously, that we are bringing people into a system, right, that has rules and regulations. So we prepare our patients to be mindful that we are aware, we want to be able to give them treatment totally confidential. That information is not going to be shared with no one else except with those that need to know. We actually navigate the person into the various resources that they may need, because we all have to admit to one piece, especially those of us that are used to working with immigrant population. We're dealing with a health issue. But they bring a lot of issues with them. It's not only the problem with health. You have the issue of housing. You have the issue of probably food security. You have issues, a whole bunch of issues that come along with poverty that we have to be aware of. So we need to learn how to assess. We need to educate. We're dealing with mental illness, obviously. We're dealing with post-traumatic stress, as we actually heard, teen suicide, mistrust. There's a whole host of issues that we need to deal with. It's just not educating, but being able to assess and identify what our population actually needs. Now, as a social worker, when I was working at the Ralph Lauren Center, I worked with a group of navigators. So the role of the navigator at the center was to identify where were the barriers that kept people, whether coming into screening, whether it was getting a diagnosis, following up with tests, or even when they started treatment. What prevented them from following up with treatment, coming in for their chemotherapy, going for their radiation treatment, or even to come in to a doctor's visit for follow-up. So my role, once the navigator identified the barrier, they refer them to me. Okay, what is the problem? Let's assess. What's going on? Why aren't you doing what you're supposed to be doing? And then obviously my role there was to alleviate a lot of the stress, whatever was going on. A lot of the issues is just simple of resolving concrete services in many cases. A lot of people said, well, you know, if I'm going to come to chemotherapy every week, I don't have access to transportation. How am I going to get here? Let's say we were located in Harlem. So if they were coming, let's say, from Queens, which is a big distance, how am I going to get there? I don't want to take a subway. I don't want to be exposed, obviously, to germs in the subway. You know, I have a compromised immune system, right? Yes, we understand. So me coordinating car service through Medicaid for those patients that had Medicaid. And as simple as that, resolving that issue, that relieved that stress. And they could concentrate on the fact, okay, I have to be every Thursday at my chemotherapy appointment at 10 a.m. And the car service is going to pick me up at 9 a.m. So everyone was ready, to come in and get their treatment. Obviously, there were many instances that the patient did not understand the whole process of their treatment. Obviously, the doctor will explain, and sometimes the information came in one ear and came out the other, especially they had to switch treatment. So the doctor basically did not have the 20, 30 minutes to sit down and assure what the whole process. So I would come in and I said, okay, let's go and sit down and I'll explain the whole process and just spoon feed them until they would understand what the whole process with their treatment. Obviously, we already touched upon me being able to address the issues of food security, clothing, shelter, transportation. And for a lot of the patients that were sometimes working 2 or 3 jobs, and knowing that now I can only probably work maybe 15 hours a week because I have to dedicate some time to my treatment. I may not have the energy to work my jobs. How am I going to replace that income? What services, what resources are available for me to get what I need while I'm still receiving treatment. These were things that, as a social worker, we are trained to do, but that a community health worker can learn how to do as well and serve as a support system to a social worker. Because we are good at assessing and knowing what the resources are. But when you are working in a center, like I was working at a center where sometimes we had 100 patients at one given time in treatment, for one social worker, it's impossible. But if I had a community worker, right, or a promotora working alongside, I says, okay, I met with this patient. These are the needs. This is what I need you to do for me to follow up. Coordinate transportation for these 5 patients. Coordinate home health services for these patients. Try to see, I'm going to give you this booklet and try to find out what we need to do for this patient so that they can go and apply for disability. But I already know because I have done an assessment. So the promotora or the community health worker is my helper. A lot of the times when patients have terminated treatment, doesn't mean that they stop being patients. You still have to follow up with them, right? You still have to provide them with the services because things do change, especially when a person has had any sort of chronic disease diagnoses. Once they have been cured or they're being managed, there's always issues that come along with that. So you don't stop treating the patient. You don't stop following up on a patient. So I had many cases of patients who I never saw during the treatment because I was not working at the Ralph Lauren Center, but came to me with issues like 5 years after their diagnosis, and they got a recurrence of their cancer. So there was another host of issues that came along with a cancer recurrence and what I needed to do. In many cases, I would have to coordinate long-term, home health, because sometimes it was just giving them treatment to palliate symptoms until the good Lord would call them. Sometimes it was just coordinating hospice services. So, there is a whole host of issues that obviously a community health worker could be of help in a certain way, but the psychosocial piece that comes along with that. So a social worker should never be intimidated by the role of a promotora or a community health worker. As community health workers, as promotores, you are our helpers. And this is what we need to, kind of educate others. Now, I am not going to continue with that, but these are the things that obviously will affect how we actually perceive our work in the sense of how we're dealing with people. And these are things that I want you to think about. How we as healthcare providers as a whole, how we actually identify our patients when it comes to sex, age, biology, health behaviors, the social environment where our clientele or our patients come from, the physical environment, health services and quality of medical service. And I just want to share something with you because it was just really disturbing to me, but then it made a lot of sense after a while. When I started working in Harlem at the Ralph Lauren Center, I had a patient who had lung cancer, but she had been suffering from sickle cell since the age of 15, African American. Lady had a very hard life because, when having sickle cell, it's not a fun disease. And then ending up with lung cancer, it's not fun either. So her lifestyle had to change completely, walking around with an oxygen tank all the time. It was very tiring, and we would try to push her to come in for treatment, for her to follow up, and she sat down with me one time and she says, "Jackie, I just want to leave." And I said, "What do you mean you want to leave?" "I just want to go back home to the Lord." Okay. He says, I'm tired. I'm tired. I can't do this anymore. I really can't do this anymore. He says, I've been suffering ever since I was 15 years old. But then she started telling me about her life story. And this is something that we have to keep in mind with our people of color, okay? Immigrants. We come with a situation where we think that we're going to have a better lifestyle in this country, okay? And what ends up happening is that you step forward, right, 3 or 4, and then something happens and you double, maybe 6. So when you think you're getting ahead, something happens and it brings you back. And sometimes you just get tired of doing the same thing over and over and over and not getting nowhere. Sometimes we fall victims of the system. And this is why I keep saying that we are victims of also the internalized racism, because we actually believe a lot of the messages that are given to us. And we have to stop that. We cannot give people that power to decide for us based on our race, based on our behaviors, based on what we labeling. That has to stop. Okay, the labels, the stereotypes. We need to be evaluated as individuals that are valuable. And I work a lot the piece of spirituality when it comes to disease, because all diseases have a spiritual component. All diseases. So as promotoras and community health workers, one of the things that I really would like to go is into the panel discussion, because I really want to get your thoughts and what you have experienced in your own work. Based on what has been discussed thus far and the presentations that you have heard today, what do you see as challenges in our outreach work with patients, with clients, dealing with these mental health issues or health issues, understanding the social determinants of health and what are the barriers faced by your patients or clients that prevent them from being an effective promotor or community health worker?
As an answer for the first question, in Oklahoma and focus in the Hispanic community that I serve with my organization, in the area of mental health, I think we have seen that it's very difficult for people to identify the issue, to identify that they need, look for help, fear to get close to those medical providers, and definitely language barriers is one of the main issues. We are one of the organizations that has more therapists, bilingual therapists in Oklahoma, but it's still lack of fear, no? At that point, it's more fear to go to us and identify they are having any problems or any issues to deal with.
For us, we are in a rural community where you have the pipe sunshine in. And one of the things that we found is that when it comes to mental health, a lot of people don't want to be identified as mental health because it's a small community and everybody knows everybody else's business. So therefore, and excuse me if you think I'm insensitive, but nobody wants to know anybody else gets a crazy check. So what happens is that they don't want people to know. Another barrier is that when you identify these people, or you working as a community health worker, or you're working in the community and you go and provide services, it's the illiteracy we found. We found that we're working with families. They're given all this information and all this paperwork, and they're told to take it home and fill it out, and they don't understand. They're illiterate. First of all, it's a mental illness. Second of all, there's a stigmatism that goes with that. And then the rest of it is the paperwork that goes along with that. So we actually have to go out to them and provide the services and say, let's just see what you got. A lot of times it's minor. but they don't understand. All they have is all this paperwork that's been given to them. And I think they just have to have someone help them to go in and kind of weed through and kind of take a little bit of the burden from them, because their packages come with this. You'll go in to help someone, and the next thing you know all about their mama, daddy, their sister, brother. But that's just a part of being a community health worker. You have to listen to the whole package first, do all that, then you get to finally address the problem.
I think I have a very aggressive group of community health representatives. They face a lot of barriers, and in order to overcome these barriers, they have to be aggressive and still continue to go out and meet with their community members, with their clients and their patients. I think we are looked at as only drivers, and we hear this a lot. You're just a CHR, and that's really detrimental to their ability to deal with their clients. But they keep on, and they know the situation, and they know what needs to be done in the communities. I always tell my CHRs that you are the bridge between the clinics and the patient. And the doctor has no idea what goes on in the home, in the environment, even in the family situations, and some of the things that the CHRs run across when they make home visits and they're out in the field. It's really a scary situation. And we can see why that elder goes in with a blood sugar of 500 or 600, and they know that, but does the clinic know it? And I think one of the barriers we have to overcome is being known about who we are. We need to be recognized as a part of the healthcare team and not just shoved out there and say, you're just a CHR. We hear that all the time, and I think that has to stop. And one way that I feel like we can do this is to get more education. Our education dollars have been sliced about as low as they can be sliced. I try to put together trainings for my CHRs that are at no cost. I try to bring in presenters, bring in educators, and I make sure that they do have some type of training all through the year, but they really need to have specialized training that costs money, and we don't have it. So we need to look at dollars and getting our community health representatives and community health workers educated, where we can have maybe yearly conferences that are geared just for them. And they're a very unique group, so I think sometimes people don't understand the unique needs and trainings that they do need. We also run across, we're in very rural areas, and a lot of our elders, there's language barriers, and we have to make sure that there's some type of education within the tribe or our groups, that people at least know the very basic of our languages. So usually once or twice a year, I have some of our fluent Creek speakers come in, and they train the CHRs to at least recognize some of the very basic terms. And this helps them to go out and reach out to our elders and the people who do speak the Creek language fluently. And I also think sensitivity training by each physician that's brought in, and each RN or director of a program, they need to have sensitivity training. And just like Mary Helen said, that sometimes they're silent, there's pauses. So when the doctor talks to them, they think everything's okay, and they're in a hurry to go see the next person, so they don't take time for that person. And that's because they haven't been trained to be sensitive to the Native American needs. So these are some of my barriers. What about you?
Based on a lot of the presentations from today, I would say that one of the biggest things that I've noticed, not just in my own work, I didn't mention this when I introduced myself, but I've worked in HIV/AIDS prevention and education, STD, and harm reduction, and I worked in that field for 8 years, and I continue to be connected to it. And when I worked in health education, which was peer-to-peer, I co-coordinated the empowerment program, which is a CDC Debbie model for gay, bisexual, transgender individuals, and of whom many were HIV positive, and they were mostly youth. Well, there was a clinic that served positive people that was connected to my building. And during the 5 years that I worked at this one nonprofit, I didn't know anyone in the clinic. And a lot of the HIV positive youth, who were mostly of color, would come to my program and talk to me and visit with me and tell me about their lives, and they wouldn't go to their doctor's appointments. Well, nobody from the clinic ever reached out to me as a health educator to tell me, you know, it wasn't until after I quit there that I learned this, and I thought, well, wow, you could have come and talked to me, and I would have connected you. And since that time I have, and this includes in New Mexico, HIV is predominantly among that community, gay, bi, transgender men, like it is in the country, and mostly of color. You know, in New Mexico, African Americans represent only 2% of our population, but I believe 6% of HIV/AIDS cases. So at our program, we had a lot of young black youth that needed to be going to the clinic, but for many reasons, being black in New Mexico is like a triple minority, and when you're gay, even more so, because in New Mexico, there's so few African Americans. So at the clinic, and this is another thing for me with barriers, is that we are a majority minority state. We have the largest percentage per capita of Native American people in our state. We have according to the last census, 46% Hispano-Latino. So, and I say Hispano-Latino because when you go to Nuevo Mexico, there's Hispanics that have been here there for 500 years in the north. And then you have Mexicanos near La Frontera in the south. And so people don't know that. And a lot of the people who are in power positions that would be presenting like what was presented here today are Anglo, and they've come from outside of the state. So there's a huge gap between the community health workers, and how we're being served. And even today, I just recently started working for the Department of Health. I've had issues where people tell me, you know, refer these people to their medical homes. And I'm like, you've worked in health for how long in New Mexico? We don't have medical homes. I come from a family where my family is uninsured. I'm one of my only family members that has health insurance. And this is for years. Most of my life, I didn't have health insurance until I went to college and was mandated, and then when I got a job. That was the first time. And so as a community health worker, you know, these presentations actually need to be brought to our communities. And we are the connection, so we need the doctors to come to us and say, because I'm not a doctor. I have my master's degree. I have it in history and literature of the Southwest. That's what I loved. I was passionate about it. But I love my people, and I can bring this message, and I can bring it in Spanish and English, and I can find the promotora who's from Las Cruces who's going to connect better with her community. It doesn't have to be me, Javier. It could be some of our promotoras that are in the South. My coworker and I just came from a cultural competency training, and it astounds me. I am American. I'm also biracial, and I'm also gay. And it astounds me that people want everyone else to be aware of them, but then they don't look inside and think about, am I doing that with everybody else? Because I want it for me, and I want it for me now. Like, people are saying, we can't wait any longer. I mean, we can't wait any longer. This is not going to change unless we do things now. And we have to speak up, even when we're scared, even when we're intimidated. And we are the connection. The promotoras, without them, I am telling you, none of the education would be happening. They don't go. I work with a lot of undocumented families. My dad's family is from Durango, Mexico, and they will not go to the clinic. They won't go. So you need to find the promotoras that are going to help them bridge that gap so they can go.
Exactly. I want to echo what the compañero said right here. We need to work with us. We are in the trenches that we say, we are the community based. Our people don't get services because of the trust factor. Our promotores, our people, we live there. We know how it is to live in poverty, talking about our community, San Elizario, in the border communities. We know how it is to live without sewer. We know how it is to live without water, electricity, basic services. We got to identify, work together in partnerships, and advocate for the issues to get those services. How many people here, we have the luxury sometimes of living with these basic services. In our communities, we have to decide whether we're going to see our doctor or are we going to pay for our tambo de agua, water. Water, exactly, a commodity that is a necessity in our community. So us as the promotores, we know how to live with those issues, and our community, we are it. We are the resource. People, like Omena was saying, we don't go to the clinics. Our community has maybe that fear, but as promotores, we develop that trust factor. But people come to us. We work in the community. We are a volunteer-based nonprofit led by Promotores de Salud. We are it. We know those issues, so we have to work and develop these partnerships. Work with the people. Work with the doctors. A lot of challenges that we face. A lot of challenges. Let's develop community-based research. Let's develop our partnership with our schools. Provide that information and educate to work together. Don't just come into my community and study my community to death. We already know our needs. We already know. We already know what we need to do. Let's do it. Let's do it. I'm tired. You're coming to me and asking me these questions. What do we need? We know what we need. Let's do it. Let's do it and let's move forward.
You started actually to start to answer number 2 already, because you identified some of the things about water, access to clean water, transportation issues, poverty. So in answering question 2, understanding the social determinants of health, what are the barriers that are faced?
I'm going to answer the second question based in two views. The first view is from my organization. We are already a cultural competent organization providing bilingual services for the Hispanic community in Oklahoma, 9 therapists, several counselors bilingual. We cannot serve all the community. What issues, what limitates us to be effective internally in the organization? Funding or access to resources to be able to increase programs and be able to educate more the community about the mental health issues. Second, about transportation, and the third one is, and I don't know if it fits really in the determinants of health, it could, but it's the support of parents for the kids or the child that we serve at the agency, because sometimes the parents do not support those kids and they drop off from treatment or from any support or services that are receiving. The other point of view is outside of our organization. When the Latino agency or the Latino community goes to look for services in other organizations, they have the immigration issues, so they will not be able to qualify for services at all. There is the fear, there is the discrimination, there is the lack of access to services. So that's another completely different world than the world that I compare from my organization.
Number 2, understanding the social determination, the barriers. I think a lot of the barriers for our clients, and we call them clients because they're clients and they're also patients. Because when they come in, they have health issues that they don't understand. So a lot of times we'll actually reading prescriptions. And they talk about the 6% of doctors. My niece is a doctor. And because her name is Precious Harden, she's Dr. Precious Harden, people don't take her serious because her name is Precious. And when you see that and you think about that, she works with us. She volunteers a lot of her time. The other thing that we see as a barrier is we see access to health care, which we know is the big kahuna. When you have the health care issues, along with that is transportation. If they can get in to see a physician, then who's going to take care of their kids, while they go? A lot of times they don't have a place for the kids to be. And they're kind of shunned when they bring their kids in because then they said the nurses are not babysitters. So then you have all of that along with the rest of it? Is there programs that should be available for patients that go in so that doctors actually have an area? You know, as far as at the same time, they could do like a double treatment. This is Rita's theory. A double treatment when you bring the children in with the parents, see the parents, and address the child's issue at the same time. And then that way you're getting kind of like a 2-for. But those are some of the barriers that I see. You coming in, you can't get in, and when you do come in, a lot of the women, a lot of the young mothers, and the young mothers don't have a place to, you know, drop their kids off while they go in. So, you know, they don't get the health care that they need.
Some of the barriers that I see involves community education, allowing the CHRs to go out into the community and provide education, but because of the lack of funds again. When the CHRs in Oklahoma, because our funding has been cut so much that most of the time they have to go out and beg for literature and handouts to take to, if they go do a screening or if they put on a health fair in the community, they have to actually go out and beg for items. We say we have to put on our begging faces just to provide the necessary information because of our funding once again. One of the other barriers that I see is family involvement in health care. We need to educate our clients or our patients, but we also need to educate the family, because if the family isn't involved in the health care of their family member, then you know, it's just like pouring, as we say in Oklahoma, pouring water on a duck's back. But we do have to try to get family involvement. And one of the other barriers we also see is elder abuse and financial exploitation. 1 week alone, I turned in 5 cases to the Adult Protective Services, and we don't know the outcome of that, but we follow up with home visits, and sometimes things never change. So I think we need to get more proactive in looking at elder abuse with our Native American elders, and also child abuse. It goes the same way, and we find this out when we go to do our home visits. And without the CHRs going into the homes, how are we going to know this happens?
I would say in New Mexico, a lot of what's been said already, language barriers, and that includes Spanish language and then indigenous languages from Native American pueblos and the Navajo Nation. New Mexico is very rural, although the majority of the state is in Albuquerque population-wise, super rural. We do also have areas where there's not running water or electricity, and so that's a huge barrier in terms of also transportation, the trust issue, and I think affordable care is awesome and amazing, but for New Mexicans, it's going to really take a culture change in how we actually view healthcare, because sometimes people get insurance and they still don't know what to do, and they still don't have that preventative mindset even though they just got insurance. So I think all of that and the poverty, those are all different barriers that we face.
A lot of barriers that we face in our community is, of course, again, the trust issue. We would manage to basically facilitate that trust issue by going directly into the community. We live in a community where we're like in a border state, the militarization of the border. We have many barriers. A lot of barriers that we face in our community is, of course, again, the trust issue. We would manage to basically facilitate that trust issue by going directly into the community. We live in a community where we're like in a border state, the militarization of the border. We have immigration and working with law enforcement in its trust. So it's hard. And us as our Promotores de Salud, we have to work with our community. That's where we go directly to the community. What we do is we provide the information and education, so going directly to the homes. We have our program, working a lot. You know, we work a lot with our families. We've been able to develop that trust. So we go into the homes, whether it's breast cancer, education and prevention. We'll work out there. We'll go directly to the community. So it's transportation. Another issue is, again, transportation. There's out in the rural colonias and our vertical and our rural areas, there's no public transportation. It's hard. So we work that. So what we do is we have to bring a solution. We do carpooling, or we partner with agencies to come into our communities. Another issue we have is the language. Work with them. We work as translators. We work out there. We working with our community. More barriers. We issues that we face with. A lot of the time, it's just the changing of our. I was talking just about my compañera today during lunch. We got to change our mentality as a culture as well. We believe that is within ourselves. We grew up with families. We have to break that cycle. It's okay to ask for help, especially in our community. It's okay to ask for help. It's okay to cry sometimes. We work a lot with domestic violence issues as well. It's okay, to work, to open up to you. And basically that's the role of us in our Promotores Salud. That's how we are key in our communities. So it's okay. So we have to get so we can receive those services. How about the uninsured? Those are barriers that we face. We have this gap. People that qualify for, or don't qualify, for Medicaid, but then we don't have insurance because it's too expensive. So it's too expensive. So those are different barriers that we are faced with at a daily basis. But us, as our Promotores de Salud, we are key. We are into our communities, and we can facilitate this process. So, again, those are barriers that we are faced with.
There's three things that I heard just since yesterday from our community health workers and our community and our promotores. One is, what happens when they're doing home visits and they find situations at home, in the home, where they can't, there's some sort of abuse, or how do they deal with that, and what protection do they have from the federal government or from any of the agencies in the community? I know that Frank mentioned to me that his area where he works is a war zone because of the drugs, the drug cartel and everything that's going on. What happens to community health workers and promotores who are working in that area? What protections do they have? Another issue that was brought up is that actually some of the women that have been brought in with promotoras are brought in to the shelters because of domestic abuse, domestic violence. They have shared with their family that they're being abused in those shelters by people who don't understand the language, and it's scary with some of the things that they're telling us about clothes being thrown at their face from clothes that are being donated at the shelter, and sometimes they throw in the floor and they say, here, take those clothes that were donated. There's no accountability of some of the shelters or some of these nursing homes like Cindy was talking about. There's nursing homes where the elderly are being also abused, and community health workers are coming to us with, what do we do? So I'd like to find out, what do they do if they come across all of these situations? How is there a system that the federal government can have available where they can report, like a whistleblower, but they can report agencies and situations that are really deadly and sometimes even tragic in our communities. And we're facing that right now in Houston. So I just wanted to know if that's even in the plans. And you all have spoken about that as well. So I wanted to see if that's something that we can talk about now.
So there are certainly hotlines that exist with regards to finding cases, for example, of whether it's domestic violence, et cetera. But I think as far as one is, it's a question too of, is it a state agency or is it another type of organization? Because there's certainly state laws as well that would exist that I think that community health workers and promotoras would need to also operate through to understand what are the protections as far as if you are determining things that are happening in a home or other types of agencies and what supports may exist. But I think all of this feedback is certainly something that I would like to certainly take back to my colleagues in the department. There are different agencies that have different authorities, if you will, with regards to these types of issues, whether it's child abuse and neglect, whether it's domestic violence. It depends on what this specific issue is that would then determine what type of jurisdiction that there may be. But I think, Venus, certainly that's something that we could discuss in more detail, and just hearing some of these examples and making sure that you all know what the resources are that exist would be very important to the work that you're doing.
Can I just share something, because I know that New York State, and you will have to find out in your in your respective states what are the laws. But in New York, all providers are mandated reporting. So whoever is has, if you found something, you have to report, and there is a particular system. Based on your state, you have to find out who is your hotline provider to report anything in the state, what's going on. So then there is whether it's adult protective services, where child protective services, domestic violence, whatever the case may be. So it's just getting in touch. Who are your people that is in charge of the mandated reporting and who you call? So just for you to know.
We have 911 for emergencies, and then we have 211 that we can call as far as information. And on the 211 number in Texas, a lot of them are set up through the United Way. When you call the 211, it'll go through these, and I know everybody hates the automated services, but when you go through the automated services, it'll say if you want to report some things as far as discrimination, if you want to put fraud, and you can report things like that. But I agree with the part about there are certain things that you should have in place before you even get there. Mm-hmm. The first thing you should do is prepare what you're going to do and how you're going to react. I had a friend that was a community worker in another part of the state, and she got involved in a situation, and the man and the woman both jumped on her because she was trying to save the woman. And that's the way it is, in domestic violence situations. They'll protect that guy that's harming them. So you have to have something in place, whether you're going to go down with the ship, or if you're going to, you're going to get out, and to call 911. And part of what we do with our organization is a lot of us belong to the Sheriff Citizens Academy. And with the Sheriff Citizens Academy, that training that I went through, one of the things they had said is protect yourself at all costs, and don't yell help. Yell fire, because when you yell fire, more people come out than if you would yell help. They'll come and actually see what's going on. But, my advice is to have something in place. Start thinking about it now and have a policy that you're all going to abide by, not something you do in your mind, but actually policy and procedures that are in line with what the law wants you to do, and not going with your own gun.
I encourage each of you to look into having your community health workers and community health representatives trained as ombudsman volunteers to go into the nursing homes, because we're seeing more and more of our elders that at one time they were at home and the family took care of them, but now the family works or they can't afford to take care of them, so they're put in nursing homes. So the Ombudsman Volunteer Program is a good program where you go into the nursing home and make sure that they're receiving the rights that they have in that nursing home and they're not being abused. So please look into that.
So that was just last week that we announced the enhanced national standards for culturally and linguistically appropriate services in health and health care. And it encompasses many things, but yes, it provides that framework to health and healthcare organizations on how to provide culturally and linguistically appropriate services. It was an announcement that we made in partnership with the Office for Civil Rights, which also oversees in particular those who are recipients of federal financial assistance, and Title VI of the Civil Rights Act of 1964 that articulates non-discrimination based on race, ethnicity, national origin, and so gets more into detail with regards to language access and the rights of individuals with regards to language access services. The Department of Health and Human Services actually earlier this year released a language access plan as well to really articulate how we need to provide meaningful access to individuals who are accessing those types of services that are federally funded, that it's meaningful in a way that it's linguistically appropriate. The Affordable Care Act also has those measures that articulate the importance of cultural and linguistic competency. There are other measures as well that talk about non-discrimination, and in particular as we move forward with the full implementation of the law. So one of the things that I think is also important, certainly you have Venus and several others of you here who are members of the Regional Health Equity Councils, is also knowing the Office of Minority Health has regional staff. We have regional staff in each of the 10 HHS regions. The Office for Civil Rights has regional staff as well. You can get this information from our website, from the Office of Minority Health's website. And be sure that you're also connecting with our staff who are in the region and really are working in partnership with the states, but also with community-based organizations, faith-based organizations, and many others to really help address some of these health needs.
I wanted to follow up with everybody with regards to the comments that were made earlier on the issue of engaging and what are we doing. I think that if you're in this room, it's because you are a leader in your community and because you care about our community. And the point that was made earlier in the sense that we have to just stop talking about these issues and we need to start doing something about these issues, and we need to make sure that our voice is represented. I think that that starts in this room because we are the people that are willing to step forward for our community. I want to introduce myself. My name is Cecilia Roberto. I work with Pfizer Incorporated. I know everybody knows us as a drug company, but we actually do a lot of other things too. I work in our state government relations team, and my organization has made the investment in having me work in the field with grassroots organizations, much like Dia de la Mujer Latina and some other organizations that are in this room. And my job is to help you get your voice heard, coordinate efforts on issues that are important to Latino communities with regards to patient access, patient protection, protecting the rights of a physician and a patient to care for his patient as he seems fit, particularly important mental health issues, pain issues, and other issues. I am here in Texas and in New Mexico. For those people that are here from other states, I have counterparts and would be happy to connect you with those respective people. And I think that people often think that advocacy and engagement, especially with legislative officials, government officials, is very threatening from the sense of putting your name on something or saying something. But we have to have our name on the table. And I will assure you that the way and the methods that are out there that are available, it could be something as simple as thanking your legislator on a social media page for supporting something that is important to you. Thanking him is engagement. It's letting him know that as a constituent, you appreciate and approve of what he did. So it's not combative. It's not always telling people what they're not doing right, but it's also thanking them and getting that relationship and that rapport and building that access. So I would love to speak with anybody that's interested in working with me and engaging on the issues that are important to our community and our states, and also connecting those of you that are from states outside of Texas and New Mexico. Thank you so much for letting me be here.
Obviously here, what is it's certainly frightening of cases that you're hearing about. And I think you're hearing from the panel as well that there are multiple levels of how we think about intervention. One, the organization itself, the broader community, the state level, the federal level. So I think that they're certainly raising these issues. One of the things that I heard in the previous session was the willingness and the ability to be at the table and speak up and share what's happening, so that whether it's at the community level or if it's elevated to a higher level, that those matters can be addressed.